morning, everyone. Can people hear me in the back? Oh, okay, good. Looks like the mic is live. Well, good morning, everyone. It's wonderful to see so many people here early in the morning. Hopefully all of you are more or less awake. Hopefully the faculty is also more or less awake. The AV people are still waking up. That's why it took a little while to get started here. But really terrific to see so much enthusiasm about the topic we're going to discuss today, revolutionizing recurrent AMI care. And we're going to focus on early intervention and unmet needs, but we will review some of the data, some of the guidelines. We'll keep it conversational. At the end, we will take questions. So keep thinking of your questions. In the meantime, this is supposed to be an interactive experience. It's a live event, by the way, so no inappropriate jokes. Don't do anything wild and crazy because it's all getting broadcast over the internet right now. So keep that in mind. If you want to connect to the Wi-Fi, which you'll need to, there's the code and the password, as well the QR code that you can scan right now. So I'm just going to leave that up for a second or two just to give everyone a chance to get that. As well, it looks like most people grabbed breakfast already, but if you didn't, feel free to wander in the back and grab something. All right, and if you're joining with your personal device, which we're all hoping you are, that'll allow you to view the slides, access today's content, ask questions. I'm going to get them on my iPad, so if you're shy about standing up or that sort of thing, no worries. In fact, if you do want to ask a question, you have to do it this way. We don't have live mics in the room. And there will be some polling as well, so please take this chance to exercise your right to vote. I'm Deepak Bhatt. I'm today's moderator. I'm the director of the Mount Sinai Fuster Heart Hospital and the Dr. Valentin Fuster Professor of Medicine at the Icahn School of Medicine in Mount Sinai, New York. And I'm joined today by two outstanding faculty, Dr. Jennifer Reimer, who's an associate professor of medicine and at Duke Clinical Research Institute, where she's also the program director of Interventional Cardiology Fellowship, and really an amazing faculty member. I've worked with her for years. I think I've known her since she was a fellow and really doing amazing work. As well, Professor Gabriel Steg at Hôpital Bichat in Paris and Université Paris Cité, where he is doing many different leadership things, leading a department of cardiology, leading a research enterprise, leading the French Alliance for Cardiovascular Trials as well, another great colleague and dear friend. So the idea today is really to go through a bunch of quick-fire questions. That is, we'll be going through the quick-fire questions. You can just sit and dine and enjoy. And we're going to cover three broad buckets of things: unmet needs in AMI care, changing the paradigm in acute myocardial infarction care, and prospects for earlier intervention after acute MI. And by intervention in this context, I'm not really talking about catheter-based intervention. The data is already there for that in the context of MI and ACS, but rather early pharmacological intervention, including pre-hospital care. So that's really the focus of today. So let's start with that first topic, unmet needs in AMI care. And I'm going to turn to Dr. Reimer to go over some of the current outcomes and prognostic challenges for patients that come in with a recurrent acute myocardial infarction. I think we're pretty good about treating first MIs when they come in, primary PCI, when appropriate, in shock patients, mechanical support, lots of different advances there. But what about if they come back? What can we do to prevent that? So, Dr. Reimer, I turn to you.
This is a huge question, and I think there's a lot of opportunities in recurrent AMI care to improve patient outcomes and really improve getting them to the lab and getting them cared for very quickly. And you know, I think oftentimes patients who come back with recurrent MI may come back with different symptoms than their index hospitalization. They may have stent thrombosis, they may have instant restenosis, and they may have different symptoms, and they don't always recognize those symptoms because they perhaps differ. Oftentimes they come back sicker as well. And so I think it's imperative that we recognize that they are at higher risk because they've had a prior MI and really take symptoms, shortness of breath, exercise changes, all of those things that may be sort of what we think are borderline symptoms, and take them seriously, and not just classic chest pain, particularly in our female population who may have different symptoms than men. I think the other things that we have to think about are their medical therapies. So I'm an interventional cardiologist. I obviously want to get them to the cath lab, treat them very expeditiously. But I also want to think about, were they taking pharmacologic therapies at home? Were they taking their P2Y12 inhibitors? Perhaps if they were still in that window in the prior AMI, and what does that mean for perhaps reloading, or what does that mean for changes in the medical therapies that I should be considering? And then I think we just have to be very aggressive with the guideline-directed and goal-directed medical therapies in these patients, because we know that they are the absolute highest risk patients coming back.
No, that's really well stated.
So I think a couple of slides I briefly wanted to go over, and I think a lot of this should be just intuitive. So we had recently AMI quality of care mortality statistics published in this year in JACC. And you can see that nearly 1 in 4 patients, even though we know the guidelines, we have our recent ACS guidelines that have come out in 2025, nearly 1 in 4 patients will not receive optimal comprehensive care. Okay, and this continues. This hasn't changed over time. We oftentimes think of defect-free care. So are you getting all of the components of the guideline in your medical care, in terms of PCI care? And we know that many of our patients are still not getting this. We have seen in-hospital mortality and 30-day readmissions among Medicare beneficiaries that have declined, but have really stayed stagnant. And so in order to make a change in patients' outcomes, we really have to be thinking about following guideline-directed medical therapy, being very aggressive, particularly in these recurrent AMI patients. AMI hospitalizations, as I mentioned before, have declined following a relative stabilization into 2018. But I think this cannot be emphasized enough, that the patients that are returning, coming and presenting with AMIs are oftentimes presenting in cardiogenic shock. They're coming in sicker. We now have advanced MCS support that we could offer these patients. And so we're caring for patients that in the past may have not survived early on in the hospitalization, but are much sicker and are also younger. So increasingly, seeing 30 and 40-year-old patients, particularly with certain risk factors, coming in very sick with acute myocardial infarction.
Yeah, I really think this is a great compendium of statistics, actually by former fellow Dr. Wadera there. And that last point about the hospitalization rates actually increasing among younger adults, really pretty sobering. You know, there's a lot of progress that's been made in acute MI care, but that is a bit of a concerning statistic there.
And then this one always, when I tell my patients that have had an index hospitalization for acute myocardial infarction and say, well, am I okay now? Within the 805,000 myocardial infarctions that will happen in the United States, about a quarter of those will return. They may return with stent thrombosis. They may return with instant restenosis. They may return with a brand new blockage or lesion somewhere in their myocardial tree. So we have to think about aggressive medical therapy so we can reduce this number, have fewer recurrences.
And you know, that number might not totally capture just the recurrent MI that's an out of hospital sudden cardiac death that ends up maybe not getting categorized as recurrent MI, but in fact it was.
And then it's really important that we think about these patients' risk. So I love this figure because it shows patients at different age categories from stratified from low and high risk. And really, what is the risk of myocardial infarction, stroke, or CV death during the first year after their index MI? And you can see within this highest category in age greater than 74, couple of risk factors like diabetes and chronic kidney disease, they just continue to rise in terms of their recurrent risk. And so how do you bring down that risk in your outpatient clinic, seeing these patients, making sure you're treating all of their comorbidities to hopefully not see them back in the cath lab? And unfortunately, it doesn't just stop at 365 days and level off. It continues to rise, particularly in these highest risk populations. And so this is an ongoing disease that we can treat the patient with primary PCI in the hospital setting during their index MI, but we should really think of this as now a chronic disease that we need to avoid recurrences.
A couple of questions have already come in. How can we prolong survival in patients with AMI? Well, stay tuned. We'll go through some of the therapies in terms of secondary prevention acutely, the goal remains prompt revascularization. That's true in STEMI, of course, with primary PCI, but increasingly the data would support that approach, certainly in high and moderate risk and STEMI, and the concept of complete revascularization as well. Another question came in here: how can we reduce the risk of cardiac arrhythmias in the first 48 hours of an acute myocardial infarction?
Yeah, I think the primary way to do that, obviously, is to make sure we've treated the culprit lesion. If there's non-culprit lesions, we've thought about that, but then we've got them on appropriate goal-directed medical therapy according to the guidelines. Obviously, keeping them on telemetry, watching for episodes of NSVT or sustained VT, and treating those appropriately.
And treating heart failure as well, which these days ends up accounting for a lot more of the arrhythmia in the context of prompt primary reperfusion. Great. Well, let's move on to Dr. Stegan, a question of the current clinical care pathway. Does it address recurrent myocardial infarction? What are the gaps?
Yeah, so it's a great question. We are fortunate to have a host of evidence-based secondary prevention medical therapies that are available to us that were not available several decades ago, but now through a series of formal randomized trials have been proven to be effective and have been made available to patients. I'm thinking of course, about dual antiplatelet therapy, lipid-lowering therapies, and ACE inhibitors, beta blockers, and then emerging therapies that we'll discuss later. So we have a lot of effective medications and measures to offer to patients in order to reduce risk. And of course, control of risk factors, lifestyle changes are also critical to reducing the risk of recurrent event. But we have several problems. The first one, I think, which is really literally the elephant in the room, is that in its general problem in preventive cardiology is that patients do not always take the medications we prescribe. And they don't perceive the immediate benefits of medications that are preventive in nature. So they don't get symptom relief. And all they see is the hassle of having to take the medications, the potential side effects, the costs related to those medications, which often can be substantial. So non-adherence is a huge issue. And it's been known in the field, for instance, by our hypertension colleagues for many years. The number one cause for resistant hypertension is patients don't take the medications. So that's a big, big thing. And we need to be very systematic in that. The second issue is that despite all the progress we've made, we don't cover all of the residual risk with the existing medications. A typical issue is inflammation. There's a general agreement that inflammation is a critical aspect of residual risk in patients with atherosclerotic cardiovascular disease. And we don't yet have the perfect tools to address inflammation. And we're not really sure whether to use colchicine. There are emerging anti-inflammatory therapies that we'll discuss later. And so there's a lot of progress to be made to address residual risk. And the last issue is that we don't educate patients well. We don't do enough efforts in patient education about what to do in case of a recurrent event. And I think that's again, a neglected area that's really important. And surveys have shown, and it's very surprising that, for instance, in a disease where time is of the essence, such as acute MI, the time to balloon and time to reperfusion in patients with recurrent MI is not shorter than in the first MI. And sometimes it's even longer, which never ceases to amaze me. But actually, we have to give patients very clear instructions about what to do in case of a recurrent event. And this aspect of patient education is really critical. We have the preventive aspect, but we also need to be educating patients about the curative aspect of dealing with a recurrent event. And again, we'll come back to that later, but I think it's a critical aspect.
I think you raised a great point. I think part of that's because when many patients leave the cath lab, they feel they've been cured. That is, they've gotten stented, so they think, well, problem's been taken care of. So I think you're right. Sometimes it almost backfires, and when they have recurrent symptoms, they're less likely to think that it's the real thing. So patient education on that point is really important.
Yeah, this slide is just to illustrate that, in STEMI in particular, time is so critical. Everything is a race to reopen the infarct-related artery and then apply the accompanying appropriate pharmacologic therapy, which will include potent antithrombotic agents, generally antiplatelet, and some anticoagulation, at least transiently. There's a whole debate about what is the optimal antiplatelet strategy according to medical management of MI. This slide nicely illustrates the various options you have according to the pathway management of ACS for PCI patients, for CABG patients, for patients who are managed medically, and for the small proportion of patients who still get fibrinolytic therapy, in whom all of these choices are really important. And I won't go into the detail of this buzzy slides, but they're essentially here to show that now there's actually quite a lot of agreement between guidelines globally, whether you look at the ACC/AHA guidelines or the ESC guidelines. They're very consistent. There are minute inconsistencies, but I think now we have established a standard of care for managing the acute MI pathway. We need to work on preventing recurrent MIs and managing the recurrent MIs. And finally, the last point I want to make is not all MI patients are equal. And again, Jennifer already alluded to this. There are patients who are at extreme risk. And the just presented new guidelines for management of dyslipidemia actually emphasize this and define a phenotype called at very high risk for recurrent events. And it's really not rocket science. It's very simple clinical criteria that can identify those patients who are at very high risk. Patients who've had 2 or more major atherosclerotic cardiovascular disease events, all patients who have 1 event and at least 2 high-risk conditions, which are listed here, which are the usual suspects: age, previous interventions, smoking, diabetes, heart failure, hypertension, elevated lipids. So nothing that, is not easily accessible when you're doing a clinic visit. And it does not require complex biomarker, complex testing. It's simple clinical criteria. And we need to get used to that and to flag these patients for intensive, not only intensive intervention, but intensive education. And I think that's really the neglected component of care so far.
Questions come in about what percentage of patients are in the high-risk category. Any thoughts about that?
Well, it's a continuous function risk. So these groupings are largely arbitrary, but there's a solid third of the patients who probably fulfill these criteria when you look at the current environment. Actually, it'd be a good exercise to look at some of the databases that are accessible to us and see and map how many patients are in there. I don't have a scientific answer, but my gut feeling is it between 25% and 30%.
But I totally agree with you. But in terms of the guidelines, really, it ends up lumping a lot of patients. It's true of the European guidelines as well at high risk, because here, for example, a high-risk condition, somebody that's had bypass or PCI. So for ACS patients, the really focus of this morning's symposium, that ends up being everybody. A related question was having to do with LDL cholesterol, how many are off target. And the average and the question was pertaining to the U.S. In the U.S., the average LDL cholesterol is about 110 to 120, somewhere in there. So it depends what you think the appropriate LDL target is. If you think it's what the most recent ACS guidelines say, which is less than 55 milligrams per deciliter in the U.S. guidelines, well then, almost all of them are going to be in that range. So virtually everyone post-ACS should be treated with intense lipid-lowering therapy. Another question here as well. Just to go back, I think actually, Jennifer, this was your talk. How long do you keep, or related to your talk, how long do you keep uncomplicated STEMI patients in the hospital after primary PCI?
Yeah, that's a really interesting question. And I think obviously length of stay, particularly in STEMI, has decreased quite a bit over time. We have seen, it was looking at our US-based data, there has been an uptick in length of stay for STEMI and non-STEMI, largely because many of us like to complete revascularization while in hospital to ensure compliance. And so the 48-hour length of stay for STEMI in the past may have gone up just a little bit to try to accommodate that. I don't think that's a bad thing necessarily, to try to get patients complete revas before going home.
Is that your practice in Paris as well, Gabriel? That is, for the STEMI patient, you've stented the ProxLAD, they've got a tight circ and a tight RCA lesion. And assuming the creatinine's okay and there wasn't some obvious contraindication, do you complete the revascularization in hospital? Do you bring them back in the next couple of weeks to get a stress test and then bring them back in the next few weeks?
Yeah, so I think there's general agreement now that for most patients, a complete revascularization strategy is appropriate once you've completed the initial culprit lesion revasc. But the question is the timing. And so there's a whole spectrum of options. You can do this during the primary PCI itself, which some of our British colleagues have advocated. And I find this to be quite challenging. I think it has a number of challenges in terms of doing the actual procedure, doing at 3 a.m. in the morning, a complex calcified lesion after you've just completed the infarct-related artery, the contrast issue and renal function, assessing the patient himself or herself, because you don't know that patient. You've just been faced with this emergency situation. So I'm not very enthusiastic about the idea of doing it on the spot during the index procedure. So then you essentially have two choices. Either you do it before hospital discharge, and that's what we do in my institution. We tend to do the infarct-related artery in emergency, and then in the next 48 hours, 72 hours, we'll try to complete revascularization with the other vessels. A lot of institutions, however, have a different procedure, and what they do is they do the initial procedure, and then they'll discharge the patient and bring the patient back for repeated PCI, and that has nothing to do with medicine. It has to do with billing. And I think, it's a fact of life that for hospitals as well as for physicians, these are real issues. The French reimbursement system does not cover the cost of all the stents and balloons and equipment you use in the procedure, so that you actually have to charge the patient several times in order for the hospital not to lose money. And so that drives a lot of the practice. It's sad, but it's a fact of life. So I think most hospitals, even the public hospitals, will tend to discharge the patient and bring the patient back within a few days or weeks in order to be able to have a fair reimbursement for the total revascularization.
It makes me happy to hear that. That is, that perverse incentives aren't just in the US, but they're also in Europe. That's really great to hear. Any final thoughts on this segment, Gabriel, in terms of recommended medical therapies?
No, I think that, this slide actually is, it's impressive when you think about it, because when I started medical school in the past century, literally none of this existed in the care of MI patients. And to think that we've come such a long way that now we have established, evidence-based antithrombotic therapies, both the anticoagulants and the antiplatelet agents, potent lipid-lowering therapies, potent therapies for left ventricular dysfunction and heart failure is quite impressive. I think that cardiology has come a long way, but we still have a big job to do, as was illustrated by the statistics that Jennifer showed.
Yeah, terrific. Well, with that, let's turn back to Dr. Reimer to discuss a little bit why reducing pre-hospital delays are especially critical for recurrent myocardial infarction, what the barriers to that might be.
So I'll speak mostly to the US. I think obviously AMI care patterns differ across the world, but in the US, it's particularly fragmented. So you may have large tertiary care centers, for instance, for STEMI care, where you may have referring or community hospitals sending those patients in to undergo primary PCI. And so it's a multifactorial answer. Patients oftentimes sit at home for a period of time, not thinking it's really happening, sort of underplaying their symptoms. Maybe their symptoms are not the same as they have been previously. They don't think it's a heart attack. And so oftentimes I unfortunately care for those patients that then have really late presenting MI and have all the mechanical complications that you might see with that. And it's very unfortunate, or have almost chronic total occlusions by the time that they come to us, suffer congestive heart failure and other mechanical complications that are unfortunate. And then we also have fragmented care in that they go to the other hospital, the referring hospital. It may be misunderstood what they're actually seeing. Perhaps, I had a patient with a left bundle branch block that was clearly having a recurrent acute myocardial infarction, but really misunderstood because they didn't have the clear changes on EKG, and so got sent a bit late to us. And so I think it has to be, especially when you have that opportunity to talk to the patient during the index MI, really give them anticipatory guidance for the future. And I tell all my trainees and at Duke that if patients are coming in, if there's concern, if the hospital's calling us, we should absolutely take those patients quickly time of myocardium, we can always make that decision. In or around the cath lab, we know that for every bit of delay that we have 30-minute delay, that really impacts those patients' outcomes. So patient-related factors, as I've talked about, situation and environmental factors, time of day, middle of the night, patients oftentimes don't want to come in, distance to the hospital, and then healthcare system factors. Is the cath lab available? Is it understood what's going on with the patient? And there's fragmented care, I think, that is particularly present here in the U.S.
Yeah, no, that's really a great summary. Let's move on now and talk a bit about changing the paradigm in acute myocardial infarction care. And really here, this is meant not just for STEMI, but NSTEMI as well. All right, Jennifer, maybe I'll start with you here about the pharmacological rationale for rapid onset antiplatelet therapy and reducing ischemic time after AMI. You touched upon some of the other things that one can do, patient level, system level things, but what about new things?
I think it's really imperative when a patient comes in with STEMI or you've diagnosed non-STEMI. So particularly in the STEMI patients, you want to get that antiplatelet therapy on board as soon as possible. And so if that can occur, at the referring hospital, in some contexts, mostly outside of the US, if that can occur in the ambulance, that is great. But oftentimes we're seeing it in the cath lab, and that's challenging at that point because you don't have adequate platelet inhibition. By the point we have a shrinking opportunity if you're loading the patient who may be in cardiogenic shock, who may be nauseous and vomiting with an oral antiplatelet agent in the cath lab. It's not an ideal situation for the patient and particularly for their outcomes. So period of vulnerability, we would all love as interventionalists to be managing primarily platelet-rich thrombus, very easy to manage in the cath lab. By the time you have fibrin-rich thrombus, more organized thrombus can be more challenging and also issues in terms of just the actual PCI itself. I think this is a really key slide here. So patients coming in with cardiogenic shock have impaired gut absorption. They may be getting opiates that you're giving them for their pain. There may be hypothermia protocols, other things like that for our cardiac arrest patients. And we know that this really has an impact on their ability to absorb oral P2Y12 inhibitors. And so increasingly we've thought about crushed, particularly ticagrelor, and our IV antiplatelet therapies like cangrelor to overcome some of these issues that we know. So this is just a very simple slide looking at oral P2Y12 effects in STEMI patients. This is our high-intensity antiplatelet agents, ticagrelor and prasugrel. You can see very quickly for both ticagrelor and prasugrel, really an adequate PRU or platelet inhibition. I think of certainly less than 200 or that 208 mark, and you can see by several hours you've gotten that in the majority of the patients for ticagrelor and prasugrel.
But it really does take a few hours for them to kick in.
This just briefly, this was the Atlantic trial, an older trial, but I think a still important trial to think about. These were patients that were treated pre-hospital with ticagrelor versus in-hospital. While it didn't meet the primary endpoints in terms of ST segment resolution or TEMI-3 flow in the infarct-related artery, importantly, there was a significant difference in terms of definite stent thrombosis, both early on and at that 30-day mark, in favor of upstream use of ticagrelor. So always great to give it as early as possible, to crush it when possible as well, per the Mojito trial. CANTIC, I think, was another important trial that really established the use of cangrelor and ticagrelor concomitantly. And at my institution, this is what we predominantly use in these patients that are very sick. And so CANTIC really looked at, is there a drug-drug interaction with ticagrelor and cangrelor, or can you give them simultaneously? And so patients were given ticagrelor, but then background therapy with either placebo or with cangrelor. And you can see absence of drug-drug interaction. Cangrelor just helps to make sure that there's little platelet reactivity, that there's adequate platelet inhibition, very quick onset, several minutes, relatively quick offset as well, which makes it very attractive for patients that, particularly cardiogenic shock patients that may not be able to swallow pills or may have poor absorption, to be indication in our guidelines for ACS. Very quickly, because we're going to talk about these in future slides. So we have this G2B3A inhibitor, subcutaneous Alan-5ban. It's given a very quick onset, 15 minutes, offset of 4 hours, primarily designed for medical responders. I think this is a very exciting field that we're entering. Selatogrel, I'm also very excited. We'll talk a little bit more about this. It's a subcutaneous P2Y12 inhibitor, very quick onset of 15 minutes, offset 24 hours, and suitable for self-administration by patients. Ziltivecumab, another investigational agent, currently ongoing trial. We'll talk about IL-6 inhibitor, very potent, subcutaneous, peak concentration in 6 to 27 days. So once monthly administration, and we'll go over the trial. And then these are just some of the ongoing randomized trials of anti-inflammatory drugs, although not all of these are acutely ongoing, but I think we'll primarily talk about Artemis, Zeus, and Hermes later on.
Yeah, no, that's really a great review. Just before moving on to the next segment, a couple other questions that came in. Is cardiac rehabilitation therapy effective for prolonging survival? Any thoughts about that?
I think there's good evidence that, particularly if you meet a certain threshold of sessions that you go to, that it can be very effective. And cardiac rehab, it's not just to tell patients, it's not just about exercise, but it's about a lot of the education. And a lot of my patients actually find a community there with other patients that have had AMI. But if you want an opportunity to educate our patients on the importance of compliance and adherence, cardiac rehab is an ideal venue to do that at.
Yeah, I mean, really, every place should be referring every post-MI patient to rehab. That's just good general practice, though it's not always done. Is there a role for anticoagulants after revascularization in the absence of AFib, especially in patients with an anterior MI without an LV thrombus? Any thoughts from either of you on that one?
Yeah, so that's something that we are exploring with an ongoing trial called Librexia ACS, where we're combining antiplatelet therapy with an anticoagulant, a novel anticoagulant, which is a factor 11 inhibitor, milvexian, which we think is a very safe anticoagulant. And the idea is that, as has been seen in stable patients in the COMPASS trial and in some ACS evidence with factor 10 inhibitors, that there might be a benefit in combining anticoagulation with antiplatelet therapy in terms of preventing recurrent events. The problem we've had in the past with the factor 10 inhibitors is that this was achieved at the expense of increased bleeding. And so the idea is whether we can use safer agents such as factor 11 antagonists to have the best of both worlds. So the key trial will report later this year, and we will see whether this is working or not.
How do you choose between P2Y12 inhibitors to do pre-treatment before seeing the coronary anatomy, ticagrelor or clopidogrel? Though I'll ask an even more proximal question, should you be doing pre-treatment with an oral P2Y12 inhibitor?
Yeah, I think for STEMI, I think it's clear we should try to preload them. I think there's good evidence for the high intensity agents. So I tend to preload ticagrelor. Obviously, prasugrel, you want to wait until the time of anatomy before you would give. Clopidogrel, many institutions have that. You can give that, especially if they have known AFib. It'd be good to load them on that because you'll end up on that therapy down the road. We preferentially load on ticagrelor. If we have an early invasive strategy for non-STEMI, we don't always preload, but if it's going to be a longer wait time, we do consider loading.
Yeah, I think the data support your answer, and the most recent guidelines also would say to do that in the US. And Europe's a little bit more wary about the concept of pretreatment in NSTEMI patients. One other question I'll just quickly answer myself. Do you think that using multidisciplinary teams can reduce the incidence of MI and improve also the life of the patient with MI, especially if the patient's obese, has diabetes? And I guess I'd say the simple answer to that is yes. These patients can be complex, especially if they have comorbidities. And I think having a nurse that's calling the patient at home, a pharmacist that might be able to help with polypharmacy and access to medicines can be very useful. All right, let me move back to Dr. Steg, and we can discuss perhaps this topic of pre-hospital administration and changing the treatment landscape for MI.
Yeah, so as has been said, the patients with recurrent MI are a very high-risk group. And there are really two incentives to give pre-hospital administration. The first one is to ensure that at the time of intervention that's upcoming, the milieu, the thrombotic milieu has been addressed by proper antiplatelet therapy, and that antiplatelet therapy has become effective. And we know it takes a while in acute MI patients, particularly if they're very sick, if they're in shock. But even for the run-of-the-mill patient, the mere time for absorption and action of the potent P2Y12 inhibitors is several hours. And we would like to have the antithrombotic milieu be addressed earlier than that. So that's one of the reasons. The other reason has not been fully validated by studies. There was the hope that pre-hospital administration would reopen the infarct-related artery in at least some proportion of patients. And as has been shown in the Atlantic trial and other trials, the data on actually patency at the time of the initial angiogram with pre-hospital administration has not really been convincing so far. So I think it's more getting the antiplatelet agents to be effective when you deploy a stent in infarct-related artery rather than hoping that you're going to be able to reopen the vessel with simple antiplatelet therapy upfront. And we're seeing here the time of action of the antiplatelet agents according to the various options we have. The GP2B3 inhibitors, eptifibatide or tirofiban, the intravenous cangrelor, P2Y12 inhibition, ticagrelor and prasugrel in purple. And as you can see, the time for action and effectiveness is much longer and much slower. And then the newer options for very early antiplatelet efficacy with selatogrel and zolunfiban, which both can be given subcutaneously in either by the patient in the case of selatogrel or in the ambulance in the case of zolunfiban. And I think that's really fascinating to see this emerging data towards the effectiveness and clinical outcomes related to using these agents in MI patients.
Yeah, a lot of what we've done so far, sort of public health efforts, trying to get patients to come in sooner. To be honest, it hasn't really had any measurable impact in the past couple of decades, though worth, keep trying to get out those messages on a public health population level and an individual patient level. But perhaps moving the therapies upstream would be the solution to actually improving outcomes. All right, let's pop back to Dr. Reimer in terms of key clinical trials that are in progress for pre-hospital therapies that we've sort of been alluding to, and what do we know so far?
I think this is a really exciting time right now in AMI care, and the opportunity to potentially change outcomes upstream of even reaching the hospital is exciting. And so Celebrate, and this was presented late last year. So 2,463 STEMI patients undergoing primary PCI randomized to the subcutaneous G2B3A inhibitor versus placebo. There was a hierarchical composite endpoint with the following components, as you can see here. And so I think really important, and I won't go into all of the individual components of the hierarchical endpoint, but for me, the fact that there was a significant improvement of all of these hard clinical endpoints that we care about in favor of upstream use of Xallium-5 versus placebo is really exciting. So this was predominantly in European countries. There were a few patients or some patients that were enrolled here in the US as well, but predominantly given in the ambulance or in the field. So really exciting to see that this upstream therapy could have real clinical impacts on patients. This shows predominantly the same thing, but I think as an interventional cardiologist, the other thing to note was that when these patients then came to the cath lab, there was a significant improvement in their TEMI flow, which is great. So if you can already come in as a STEMI patient with TEMI 2 or TEMI 3 flow at the time of PCI, that is really, really important. Absolute risk reduction in terms of 3% in terms of clinical endpoints in favor of Xallium-5. Now, SOS-AMI, another really exciting one ongoing internationally. It's selatogrel versus placebo in suspected AMI. And so these are the high-risk patients that we're really talking about. So patients that have had an index hospitalization for AMI, we then randomized them to selatogrel, which is the subcutaneous P2Y12 inhibitor versus placebo, 14,000 patients. And these are, again, high risk, previous AMIs, ongoing therapy for diabetes. So when we were talking about that high risk cohort, these are those patients. We're going to learn a ton. Again, here is the 6-point ordinal scale for the composite endpoint. And so we know that selatogrel is really attractive agent because it's subcutaneously given. This is the 8 milligram versus 16 milligram selatogrel. And you can see what the median PRU is in terms of 15 minutes. So if a patient's sitting at home and they administer selatogrel while they're calling 911 or calling the emergency services, by the time that they reach the hospital, we really suspect that their PRU and their platelets are going to be very adequately inhibited at the time of primary PCI.
Yeah, no, it's really also an interesting concept. I'll mention specifically in SAMI, beyond studying this drug and upstream therapy, the idea of a patient self-administering therapy, I think, is really quite revolutionary. That is the case that in certain disease states, you're having, allergic reaction, you or a family member, someone may inject. But in the context of ACS, I think it could potentially be paradigm shifting if the trial is positive. But regardless of positive or not, just that idea of moving therapies upstream, empowering patients and their family members or coworkers to actually initiate therapy, I think could really change treatments of ACS worldwide. One other trial that's here is Artemis, but this was alluded to before, looking at inflammation and IL-6 inhibition. But to be clear, this is really in patients once they've been hospitalized, where it's being studied, really unlike the two other situations with Celebrate and SOS-AMI, examining therapy prior to hospitalization. So that one is a bit different.
I think just ziltivekimab, obviously, we're very excited potentially for this anti-inflammatory, very potent anti-inflammatory in these high-risk population of ACS patients, to see what the ramifications and long-term outcomes of these patients could be, getting ziltivekimab, an IL-6 inhibitor, once monthly in terms of remodeling, reduction potentially of heart failure and other recurrent events. Librexia, I think Dr. Steg has already mentioned, was milvexian versus placebo in patients with acute coronary syndromes. The primary efficacy endpoint listed here. Recently terminated as the trial was found unlikely to meet the primary efficacy endpoint. And I think we can move past the intervention, a little bit different of a trial.
Yeah, just looking at lipid lowering with PCSK9 inhibition in the hospital, though, in fact, Dr. Steg's leading a very large secondary prevention trial that will hopefully report out sometime in the next couple of years. Speaking of you, Gabriel, what do you think the anticipated impact will be of these pre-hospital antiplatelet strategies on patient outcomes, ultimately if they're positive and approved in clinical care pathways as well?
Well, as you mentioned, I think it's truly paradigm shifting in two ways. The first one is patient empowerment. So involving the patient in their own care and making clinical decisions. Actually, the patient is making the clinical decision once they've been properly trained to self-inject. I mean, that's mind-boggling when you think of it, because that's never happened in the field of acute cardiovascular disease. And the second aspect is that we usually give the patients preventive medications, and now we're handing the patient a curative medication. So something that will take care of their new event. And again, that's completely new. So to me, it's a big, big change. And regardless of whether the trial is positive or negative, I think that now it's opened a new avenue for interventions in acute coronary syndrome, so that we can actually leverage the patient education to involve the patient in their own care and in dealing with the new event themselves. And if we do proper education, I mean, patients are remarkably equipped to save time and provide effective therapy. So I think it was really an incredible idea to do this. I remember my own skepticism the first time I heard this idea, of involving the patient in self-injecting themselves. And it actually works in the trial. People do it. So you can do it.
Yeah, I mean, even kids can do it, an EpiPen, for example. So I think even though it's a different paradigm in terms of adults in ACS, I do think there's really something to it. All right, despite what the timer says, because of the little bit of a late start, we actually only have 9 minutes left. So we'll just have to move through the rest of the topics at a brisk pace so that people can get out on time. But Jennifer, let me bounce back to you. How do you educate patients on when to take these medications?
So a quick overview of this. I think the key to adult learning is repetition. It can't just be in the hospital setting. You need to be doing it in the outpatient setting. Remember, when people are hospitalized, regardless of their education level, really diminishes in acute illness. And so, most individuals, if you were to study it, it's a 7th or 8th grade level during an acute illness. And so you really have to consider that and how you educate them. How do they best learn? Is it via materials that are written? Is it via verbal materials, video materials? And then continue that into cardiac rehab or into the outpatient setting, repeating over and over the importance, the why. Why do you need to take this P2Y12 inhibitor? Why do you need to take the statin? How is it going to benefit you? How can we overcome barriers like costs and other things that might keep you from taking those medications?
If I may.
Oh, yes, of course.
Yeah, I'd like to interject. I think we're, again, at the dawn of a new era in terms of patient education. We have neglected this. We've largely, said, well, it's going to be rehab. The patient's going to go in rehab, and somebody's going to take the time to explain about lifestyle and diet and smoking and importance of medications and titration, et cetera. But now everybody's talking about AI and social media and medical disinformation, and we got to leverage new tools. We got to have chatbots that explain to patients what happens if I forgot to take my pill this morning. I forgot to take my statin this morning. Should I take it? Should I take 2 tomorrow?
Right.
What happens with my antihypertensive medication? I forgot my antihypertensive pill. Should I take 2 tomorrow? What do? I have this supposed side effect. I measured my blood pressure this morning. It was low. Should I take my medication? We need to provide patient-friendly tools that are going to be much more effective and time-saving, using and leveraging all of the new technologies that are available to us. I think this is going to change in the next few years. And I'm sure we're going to have great tools to assist us in dealing with, in a time-constrained environment where there are so few physicians, so many patients, and so much to say. Well, to leverage these tools to communicate in a much better fashion to patients. And the other aspect is we also need to be cognizant of all of the noise that's around medical information and disinformation, and to convey to the patient which are the proper channels and what are the trustable sources of information for them.
Yeah, no, that's a big problem these days in terms of medical misinformation. So just to get into the wrap-up phase, we've only got about 5 minutes left. Jennifer, what do you think the main barriers are to implementing pre-hospital preventive therapies for recurrent AMI?
Some of it is fragmentation. I've alluded to already, especially here in the US, if they're coming from a referring hospital into the tertiary care center, do they recognize, say, Xalium-5ban or selatogrel in the future? Potentially, do they understand the potential benefits to the patients of those upstream preventive strategies? Workflow pressures, knowledge gaps for patients and providers, and that can be at any centers. Obviously, we're under a large constraint of resources. Clinicians and providers are working very hard in packed emergency rooms. And so this often makes it difficult to really focus on all of the upstream measures that could be made prior to getting to the cath lab.
Yeah, no, that's really terrific. A question came, I might as well ask you right now. If positive, self-injection drugs, how would they be stored? Longevity of agent, how will it be billed? Any thoughts? And of course, selatogrel is investigational, but and being studied. But any thoughts about those questions?
Yeah. So I think obviously I think with Xalium-5ban, it would hopefully ideally be given on the emergency vehicle. With selatogrel, the patients actually have we have a little necklace where they can carry it around, their auto injector. And so that's been really ideal, and it's very easy for the patient to carry around, like when they're going to different activities. They don't have to worry about keeping it in the refrigerator and taking it out. When they're at home, they're able to travel around with it. So it's made it very ideal and easy for the patient, I think would be.
Yeah, no, I mean, maybe there aren't in so many people here who have kids with food allergies, but at least in my neighborhood, I think 100% of the parents have at least one EpiPen in the household. So everyone is actually more familiar maybe than you might otherwise think is if you're an adult cardiologist with these sorts of approaches. It's not so bad. In terms of final part of that question, though, billing, I mean, obviously that would depend on the drug getting approved, how it's labeled, how the price is set, but it would be prescribing someone an injector as one does an EpiPen. Any sort of payment or billing happens up front, and then the person carries it around. It's the same sort of thing. All right, we've only got a couple of minutes left here before wrapping up. So Gabriel, let me bounce back to you in terms of strategies that can help overcome some of these barriers in clinical practice.
Well, we discussed exciting new therapies that are emerging and are being tested. And while we're waiting for the results of these trials to know which one we're going to use in clinical practice, I think the one message I would take away today that is applicable to my patients is we got to do a better job at patient education. We need to involve and invest time and effort in patient education, because that's, again, a neglected part of medical care that is so important for the issue that we're discussing today, recurrent MI.
Yeah, totally agree. Jennifer, maybe I can bounce back to you for a quick thought about how healthcare systems and clinicians can prepare for integrating pre-hospital therapies. It's one thing to have, hopefully, trials that are positive, but then, as you know, for much of the work you and your colleagues have done, implementation ends up oftentimes being the rate limiting step.
I think the big thing is, and these companies are doing a great job with this, but I think it's really imperative to go into the various healthcare systems and understand the differences and how it would be implemented. And I think it takes a lot of work. It's very much the same amount of work for the actual trial itself. And I know that they're busy thinking about implementation strategies and how you would educate the emergency room providers who are receiving the patient who's gotten selatogrel, for instance. And so I think there'll be a whole nother layer of work and efforts to help implement these strategies.
Yeah, no, totally agree. And Gabriel, any sorts of final thoughts about what the future might hold for recurrent MI management in terms of innovation and patient care?
Well, the one thing we didn't touch upon today is our ability to predict events. And again, here, I think this is a whole new area that's opening where, you and others are working in using imaging, for instance, leveraging imaging to identify vulnerable lesions and vulnerable plaques and vulnerable patients. We also have all of the use of artificial intelligence to make individualized predictions for diseases that is booming as we speak. And so I'm pretty convinced that in the next 10 years, this is going to translate into clinically applicable tools for prediction. And that's also going to change completely management of our patients, our ability to individually predict the risk of patients in a much more refined manner than what we do clinically with the fairly crude clinical assessment that we have.
Yeah, no, I know you're doing a lot of great work yourself and your center are using AI and other innovative approaches to do just that, figure out who's really at risk of recurrent ischemic events. So if anyone has any other questions, please go ahead and log them in so I can take a look here at my iPad as we are concluding. Just some thoughts to leave you all with. Preventing recurrent MI requires ongoing, personalized outpatient care beyond the initial hospitalization. Of course, the initial hospitalization period is important too. Early intervention and optimizing secondary prevention are key to improving outcomes and reducing recurrence. And we touched upon many different approaches, antithrombotic approaches, touched upon lipid-based approaches, emerging potential anti-inflammatory approaches. And finally, then clinicians must address these unmet needs, ensure strong follow-up. Adherence, we talked about quite a bit, a real ongoing challenge. And then coordinating care, just as someone asked the question, really important in terms of approaching this with team-based care. Well, with that, I'd really like to thank everybody, and it is right at 8 a.m. But if people have questions that we didn't get to, I did get through everything on the iPad, but if you have things you want to ask the faculty, I think they can probably stay around for 5 minutes or so afterwards. But thank you so much all for coming. Hopefully this was enjoyable. As you can see, lots of exciting things going on in the world of the post-ACS patient. Thank you very much. Enjoy the rest of the meeting.